So that's my role. Well, it's a good time to talk about updated findings because yesterday we published in my research group, National Confidential Inquiry, we published the first academic paper on suicide rates in England since the pandemic began. So this came out in you can see the journal there, one of the Lancet family of journals. There's our research team mentioned there too. So I hope, let's just try and get the laser pointer where I need it. So there's the team, very important to acknowledge the rest of the team, a lot of hard work from people, but in particular, hard work too from your colleagues, maybe some of you, the STPs who are part of this national programme, because to estimate suicide rates nationally, we called on the real-time surveillance data that many areas were collecting. So just in case you're not part of that discussion previously, it hasn't been possible to monitor the impact of COVID on suicide through the conventional suicide statistical collections, which are based on coroner's inquests. And that's because the inquest system has been itself so disrupted by COVID. However, many parts of the country have had real-time surveillance, which means recording suicides as they occur, and they are an important potential source of data. Most of those systems have been used for local purposes. So this is the first time that we've tried to combine local data into something like a national picture. And in order to do that, therefore, we've had to rely on those STPs that have got well-established real-time surveillance systems and are reasonably confident about data quality. We've spent a lot of time on data quality. So to do what we've done, we ended up with 10 STPs participating from the national programme. They're shown on the map there, the dark areas. Some of those STPs are merged with others, but in their original form, it's 10 STPs with a total population of about 13 million people. So it's about a quarter of the country, very large base population. And our aim has been to record figures throughout 2020, combining suicide data from each of these STPs month by month. From the beginning of 2020, the pre-COVID months, pre-lockdown months, January to March, and then the subsequent months, April to October, which takes us from the beginning of first national lockdown essentially until the beginning of the second national lockdown, which began at the beginning of November. So it's April to October is our key post-lockdown period. That's what we've done. Now, the main comparison is between those pre and post-lockdown months in 2020, and that's because the issue of recent data collection is an important part of quality. Early data collection in some parts of the country inevitably means some uncertainty about data completeness in the early period. So the most likely reliable comparison were the immediate post-COVID months and the immediate pre-COVID months. So that's been our primary analysis. So here are the main findings on this slide. So we take the numbers underneath the graph first of all. This is the average number of suicides in that 13 million population during the time that's there. So the pre-COVID months and the post-COVID months, you'll see the total are there, more or less the same. Slightly fewer, in fact, in the post-COVID, but not enough to be a significant difference. So essentially, no change in the number of suicides that were occurring pre and post lockdown, post pandemic. Then we have the graph, which takes us beyond numbers into rates. And in the paper, there are a number of ways in which we've examined rates, but this is one of them. This is just looking at the overall rates and those error bars there are giving you the degree of uncertainty around any figure. So what you're looking for is figures that are outside the line that the other figures are drawing, there is no monthly figure that's outside the general pattern on the slide. So no individual month was different from any other month, although it's possible that October was a bit lower than the other months. But no other month was different. And if you combine April and May into what you could call the months of lockdown itself, no different from the rest of the year. And then the post-lockdown months, when society was opening up again during last summer, again, no difference. So really no difference across the year. We did do a secondary comparison, which was with the equivalent months in 2019. And for the reasons I've said, that's less reliable because early data collections possibly not yet mature. But there again, there was no difference. Now, some people ask me about seasonal variation, how that might affect the results. The seasonal variation in this country puts up the number of suicides between April and June. It's a relatively small effect, actually, but it does put the numbers up. And if we'd found a rise post-lockdown, then we would have to have excluded seasonal variation as a possible cause. The fact that we didn't find a rise means that there is no confounding here. There is no sort of interfering with the results, so to speak, as a result of seasonal change. So what did we conclude? Well, first of all, if you remember, when the pandemic first started, there was a huge amount of concern about what some people talked in very alarming language about a suicide epidemic. And so I think we can be fairly confident that very large national rise that many people feared and some predicted has not happened, at least not in these areas making up the quarter of the country that we studied. In fact, on the areas that we have data on, we're not seeing any rise. But it's very important to be cautious about what broader conclusions you can draw from that. We've got pretty good evidence from other studies that people have felt more distress during the pandemic. So we have to, in the end, place our findings alongside credible evidence of greater distress. There are also a number of caveats, a number of uncertainties. Every research study has uncertainties. In fact, one of the main aims in research is to address uncertainty and to discuss it, to take account of it. So the uncertainties here are, first of all, that these are early figures. They cover the early months, 7 months post-lockdown. They are overall, I suppose, quasi-national figures, but it may be that there's variation between different parts of the country, and that there's some parts of the country that have been affected in a different way from the national picture. These are overall population figures. It may be that some groups have been more affected. After all, the pandemic itself has not been uniform in how it's affected individuals and communities. And then there's the point I'm making about relatively early use of real-time surveillance for this kind of purpose. It still is a developing technology. I suppose for most of us in suicide prevention, the main caution here, the main uncertainty, is that suicide rates are generally quite sensitive to serious economic adversity. And if over time there is a more serious economic downturn, then that may change the picture markedly. So our concern is still that suicide prevention remains a priority, that we're conscious of the risks which haven't gone away, and that we recognize that in the coming months there are potentially new risks for people who may be economically vulnerable. So the findings are positive as far as they go, because they don't support the anxieties that people had over suicide rates, but they're quite early figures, and we need to remain vigilant. They do, though, raise that issue that I mentioned. How can you have more distress and yet without a rise in suicide? And so in the paper we discuss the possible reasons. First of all, it's important to say that suicide is more than a reflection of mental disorder. Suicide rates are complex. And to give you the most obvious example, the highest suicide rates are always in men, and yet the highest rates of depression in pretty much every study are in women. So at that very basic level, suicide rates do not always follow rates of mental disorder. So we can't easily jump from one to the other. Secondly, it may be that for some people, as well as risks, there have been greater protections, vigilance from family and friends and neighbours, and support from services. There may be that the lockdown period reduced people's access to certain suicide methods. It's quite a difficult thing to talk about publicly for obvious reasons, but reduced access to means is one of the most important suicide prevention approaches, and there are some methods that would have been less accessible during lockdown. Then, of course, there's the broader social understanding of suicide. Societies that are more coherent tend to have lower suicide rates, and it may be, for a period at least, we were a more coherent society, getting through a crisis together. That sense of common purpose, mutual support, protecting people who might have been more vulnerable. It just so happens that by coincidence, a week before our paper came out on suicide rates in England, there was an international paper about suicide rates post-COVID around the world. I was one of the authors, but actually it was led by colleagues in Melbourne and in Swansea. So this slide is quite a creative slide produced by some members of the research team, this international research team. And they are, in that slide, summarising some aspects of the methodology. And I suppose the first one to mention is that this is an attempt to combine data from different sources, published and sometimes unpublished, from countries around the world that have got reasonable quality data. And in the end, in our study, there were 21 countries, and they're shown in, these are the shaded areas on that sort of half globe that's there. And you can see that prominent there are countries of North America, Australia, some countries of Europe, mainly high-income countries. And so it's very important to recognise that this is not a representative sample of the world population, most of whom live in poorer countries. But the key finding was that in these 21 countries, there was very little sign of any rise in suicide. So that was the creative slide that the research team produced. Here's my rather more statistical slide summarising the main result. And so I don't expect you to read this result. It's the image that I want you to see here. So in that, there's the paper, by the way, here. So published in Lancet Psychiatry about a week ago, 2 weeks or two ago. This is the main table. And as I say, you don't need to read the detail. It's the image that I wanted to get. So how this works is that this line here is essentially the suicide rate that each participating country had before the pandemic. And then each of these horizontal lines represent the figures that have come out since the pandemic. And what we are examining for is that the post-pandemic figures are falling either on the line, which would suggest that they are no different, or are falling outside the line. So there's an example of one which is outside the line. It's not crossing that line at all. In which case, and in fact, there are almost no countries where the figures were higher. There were several where the figures were lower. And so the conclusion of the study was that suicide rates in these 21 countries have either remained unchanged or they've fallen. But there are some important caveats again. These are against the early pandemic, the first few months of the pandemic, not more recent than that. Some of the areas there's quite a bit of variation around the world. But essentially, most of these figures are touching the line. You see each of these horizontal lines touching the main vertical line. And statistically, that means that they haven't changed. So our figures in England are partly given additional validity by this finding that they're consistent with international evidence. There is one different result, though, and that's in Japan, where you may have read about this. initially, these are the Japanese suicide rates, where in the early pandemic, that's here, they saw a fall in suicide rates. Incidentally, Japan didn't actually have a formal lockdown, but then they saw a rise, and this is the rise over the later months of 2020. And it now seems that rise has been linked to the economic position of women in Japan. It's mainly a rise in females and in young people, influenced by celebrity suicide that happened to occur during this period. So factors which are, you could say in a broad sense, cultural. Incidentally, more recently, Japan has published figures which show this rise beginning to turn down back towards where it had been. Okay, so suicide figures, we're getting a much clearer picture now than we had even just a few months ago. But what about beyond suicide itself? Here we draw on a very important study conducted by UCL called the UCL COVID Social Survey. And in the social survey, they're looking at data provided by a large population of volunteers across the country. It's a big study, 70,000 people. Those people are essentially recycled. They fill in forms and provide data at regular intervals every few days. And so the study is very good, therefore, at getting continuity. When it can show change, that change means something, maybe more than the actual figures. Bear in mind, this is a volunteer sample. So this is an example of one of the things that the UCL Social Survey has asked. It's four graphs, but you get the idea from any one of them. This is a timeline. And this is the initial lockdown right at the beginning. Unfortunately, there are no pre-lockdown data. And you can see that this is COVID stress. That the stress levels, the number of people saying they felt stressed, relatively high in the early pandemic, and then fell as people felt more reassured. And then towards the end of the year, as some restrictions came back, feeling more stressed again, and then more recently falling again. That's a typical pattern, and it seems to be similar by age groups. At the bottom here, this is the same issue, COVID stress, but showing people with and without a mental health diagnosis, generally making the point that they're following the same pattern, but with higher rates of COVID-related stress at all times. So this is giving us an idea of people's anxiety about the pandemic, but our concern is primarily about suicidal behavior. So in the UCL study, they also have self-harm data. They ask people about recent self-harm. And you can see that if we take this top left, which is the population divided by age, despite the fact that there is variation in the stress figures that I've just shown you, there's very little, if any, variation in risk of self-harm. The line pretty flat throughout the whole time. And although there's some volatility in the youngest groups, there's no overall change. Again, people with a pre-existing mental health condition showing the same pattern, but higher rates. So this is self-harm in the community. This is a population sample. We know that most self-harm doesn't go to hospital, but you could say that the more medically serious self-harm goes to hospital. So it's a very important measure as well. And here we've been monitoring self-harm attendances at hospital at two of our sentinel sites. So nationally, we monitor self-harm at a number of hospitals across the country. And here we have the findings from Oxford and from Derby combined. And what the slide is showing is the month-by-month breakdown during the pre- and early pandemic periods of last year. So first of all, this is the pre-pandemic period, and the grey bars are the self-harm attendances at hospital. And you can see that as the pandemic began to strike and lockdown came in, self-harm attendance at hospital declined fairly substantially. Post-pandemic, it recovered to some extent, although it didn't, during this period of study, go back to its previous levels. The black line here is the previous year, 2019, for comparison. So a suggestion that hospital attendance went down, but community rates remained more or less as they were, at least in the early pandemic period, during and post-lockdown. However, here's another study now from the same Oxford team led by my colleague Keith Horton. And this time the study is about reasons for self-harm. And to do this study, the team asked the clinicians who were making self-harm assessments to record the reasons that people were presenting with. It's a case series or continuous sample of people, quite a large number of people. And the clinicians themselves were judging whether these potentially causal factors were in any way related to the pandemic. And what they found here is that about half the people who presented with self-harm included factors which could be interpreted as COVID-related in their reasons for self-harm. So a large number of people. And that was particularly true in females. And some examples of the stresses that they were reporting are on the slide here. They're given in sort of numerical order, starting with the most common. So people talking about their mental health being worse or losing support. People referring to isolation and loneliness. Losing contact with people who might have been supportive. Loss of routine, feeling trapped. Conflict. Economic pressures there. Fear of COVID itself. Quite often people reported more than one factor. So it's an important balance that we're striking here with the evidence. We know that people have been more stressed, that the COVID pandemic has had a significant impact on people's mental health. But at the moment, at least in the early pandemic months up to last autumn, we aren't seeing that distress translated into higher rates of suicide and self-harm. We don't yet know what the long-term development of those figures will be, and we don't know yet whether subpopulations, young people, ethnic minorities, people who are economically distressed, we don't yet know what the effects for them will be. We do know that when people talk about their self-harm, they include COVID reasons as part of the causal complexities. And so we have a balance to strike here. We have to understand that COVID is impacting on people's mental health and may be affecting the reasons that lead them into a self-harming crisis. But at the same time, we're not at the moment seeing COVID as a driver of rising national rates. Now, this is important because we're now entering a new phase, at least I hope we are, in the pandemic, a phase where society has the chance to recover and reopen. And many of the risks for suicide will still be there, but some of the protections could be lost, the vigilance and mutual support. Some of the economic stresses could get worse. And so nothing that I've said should make us think of suicide prevention as any less of a priority. In many ways, we have to redouble our efforts as we move into the next phase. I want to thank you for listening. Just acknowledge the National Confidential Inquiry team that have done the majority of the work that I've described. This is how we used to look in happier times, and this is how we look these days. Thanks for listening, and take care.
Thank you so much, Louis. It was completely fascinating. And you come and do these updates, or you and Nav do every couple of months, and I learn something new every time. So it's a real testament to the work you and your team do and how you present it. I think I just want to, we're at 5:30, but I just wanted to put a couple of questions and also just check if there's anything else. But I suppose I wanted to start with so there's a couple of comments in the chat that went as you were going along. So first of all, from Louise in Somerset, well, it's not another question, but just kind of suggesting that the numbers in Somerset, which is was one of the 10 STPs for the real-time surveillance, I think. She's saying actually it looks like numbers since October are starting to rise and have been high kind of through to March in Somerset, which I guess backs up what you're saying, and one of the caveats that I know you always give about the data is early data and we don't know the kind of long-term impacts of COVID. And then but then the question, which I think I want to add to the question a little bit as well. So Liz in Suffolk has asked if there's any data to support a rise in numbers in middle-aged females or women. And so I was going to ask a similar question about whether you'd done any more kind of granular analysis around different demographics or different areas of the country to see what the variation looks like. I know you said there may be local variation, but I wondered if you'd seen any in the STPs you worked with.
So just to emphasise again, I think that's the comment from Somerset's very important, because I think we're the first to point out the cautions about the data, of course we our intention is to carry on monitoring as long as participating STPs will help us. We'll continue to do that, and if the figures go up, then obviously we will make that known in exactly the same way. So we just need to ensure the best accuracy we can. I mean, I think it's fair to say that there is variation around the country. Some areas have actually seen a fall in suicide since the pandemic started, and one or two have seen a rise. We did make a commitment not to talk about each individual area. It's partly to protect them from getting multiple demands. So we haven't. So if you don't mind, I won't actually say which areas are going in which direction, but it's true to say that there are some where they had a rise, and it's not, even then, it's not quite straightforward, because some areas had a couple of months where the figures were high, and then they went back down again. So over time, even the rises are not sustained. And I suppose if you think about it, every year when we record suicide figures through the conventional coronial route, even if the figures are the same year on year, there will be some places where they've gone up and some where they've gone down. There'll be some parts of the country where they had a sort of temporary rise, and then a change in direction. And I think that we just need to bear in mind that what we're describing here is the overall picture as best we can do it, but that doesn't take away from the importance of monitoring locally and acting on local data. Local data are a bit more subject to volatility, of course, but even so, it's really important that we have both. I'm sorry, we don't have a demographic breakdown yet of age and sex or anything else, but of course that is where we should go next.
We've got more questions, I think more people or more comments, but we're over time with this, and I think I'd really want to not take any more time off of people who are going to present about their work, if that's okay. Louis, I'm sure that some of this discussion can inform what we talk about at the next learning set and possibly the workshops as well, and I don't know if there's any kind of discussion can continue in the chat while we move on, but I think I probably have to move on to the next slide. So thank you everyone for your comments and questions, and thank you again, Louis, and all of your team for a really great presentation, interesting presentation and answers.